Good afternoon to everybody, to all of you. Thank you for joining. This is, let me say, I'm glad to introduce Dr. Ari to the first Esaote Ultrasound International event. Okay, today this event webinar is focused on general imaging application, in particular on liver, but it's our intention to prepare a calendar. So in a roadmap in the next weeks, in order to perform other webinar, probably online activities, in order to share with you all how the Esaote technology, I mean software and our application can provide you, okay, a solution for the use of ultrasound in clinical application in specific application like abdominal, but also vascular, cardiology, and OB-GYN, women healthcare application. So let me just say that behind this software development that we use to talk as an argument of discussion during the webinar, for sure there is a team of engineers that represent the 13 years of experience of Esaote in this business in the healthcare. But always there is a continuous collaboration with you, with our special customer, doctors in general, because it's a crucial point for us to listen, collect your voice from field in order to facilitate the way we used to facilitate the diagnosis, the treatment, and also the follow-up of the patients. Also improve the quality of the life of our patients in general. So anyway, let's start and let me introduce again Dr. Andrei Hari. Dr. Andrei Hari is a specialist of internal medicine at the Department of Gastroenterology and the General Hospital of Celje in Slovenia. Okay. Thank you, Dr. Ari, to stay here. Today, Dr. Ari, the presentation will be focused on the elastography, the use of the shear wave elastography in on the liver in clinical practice. So thank you, Dr. Ari. I leave you the stage, and I remember to everybody that in case of any kind of question, it's enough to write inside the specific box at the end of the presentation. We'll find a way to answer to most of your questions according to the timing that we have. I think that's all. If Dr. Ari is ready, I'm glad to leave you the stage. Thank you. I switch off my camera in order to optimize the signal. Okay. Thank you.
Thank you, Francesco. So Andrei Hari is my name. Everybody welcome. Thanks to Esaote for hosting this event. I hope that everybody can hear me and see me also. Let's take a bit of our time to talk about elastography. We will go through some theory at first. I think that everyone is well accustomed to the sheer basics of the technique we are talking today. So there are waves that are produced via ultrasound signals. They travel to the liver, and then they travel slower through normal tissue and a bit faster through tissue that is sicker, such is the case in liver cirrhosis. But the main question for me would be, why talk about CHEVE in 2021, since elastography is on the market since 2007, or maybe it's from 2013? Maybe on one side, because we all know that elastography is very patient-oriented, it's non-invasive, it's reliable, it's dynamic, it's able to assess a great quantity of liver parenchyma, and it has mainly substituted the gold standard that was used in many chronic liver diseases before, that was liver biopsy. But if we leave non-invasiveness aside, I think there's another important issue that we should discuss today in the last topic area. I think it was 2016 when I read a well-presented paper by Professor Giovanni from Italian group entitled Elastography, a major stage for many different actors, meaning many different techniques, many different computer systems on the market, but the major question would be different or the same. If we put aside the strain part of elastography, we had a solid basis of 3 shear weight techniques that are comparable but a bit different. We all know transient, puncture wave, and 2-day shear weight technique applications. And in today's lecture, I will try to focus on the second one, so on the point shear wave application data, how to use it in clinical practice. Before we go forward, not to forget that as of 2020, there are 3 study-validated systems that are underlined here. So for transient, that is of course FibroScan, for point shear wave, that is of course Siemens, and for 2D application, that would be France Explorer. The main thing to experience or to get from every point shear wave session is to be able to obtain a reliable elastographic measurement. That means able to capture or perform at least 10 valid measurements. Of this, at least 60% of all measurements should be valid, and even more important, if some point shear wave systems have inert computer system data that measures the quality of the measurements. Besides having 10 valid measurements, we should always have 10 measurements that are of high quality. Then again, of course, we are always looking to the ratio between median liver stiffness measurement and interquartile range. That is the measurement of the statistically scattered signal throughout the median value, and then we are trying to obtain it, the measurement that we are having is valid. Of course, there are some other internally defined issues. There is some international consensus to measure the same scores, the same numbers, measurements in at least 2 different intercostal spaces. Why? Because some of the diseases, as chronic liver diseases, are projected a bit more focally distributed throughout the liver tissue, and that would be the reason behind this technique. Another one, we should be able to perform, if possible, by the patient, every measurement in the peak expiratory point of the breathing cycle. If not possible, the patient should hold the breathing in the neutral position. Before I proceed forward, just take a short statistic alert. We all know that elastography is always reported in studies that have ORAC statistic behind them. So, meaning the proposition for everyday clinical use is constituted from so-called cutoff values. These are the values that have on one side enough reliability to exclude something, meaning they have enough negative predictive value, or to confirm something, meaning they have enough positive predicted value. In everyday life, we always know that elastography is very strong when talking about negative predictive values, so ruling something out, but a bit less confident when ruling something in, about projecting or confirming some clinical point that we are not as sure of. And this is a picture from my lab, Esaote, that we are using. Let's take a short peek. I think this is a nice picture. It seems like a more complex final report because there is some data that I would like to discuss. Picture seems to be well composed with all the elements that we want. There is this fine white line on the monitor screen that defines liver capsule. Then there is proper placement of the point of the measurement, the square that represents the region of interest. Also, the axis of the signal is perpendicular. The IQR and the median ratio is under 30%. But surely, if you look to the left side of the screen, we're able to see that some of the inert analysis from the computer system has alerted us that some of the data may be of medium or even of low quality. What to do with this data? There is also some graphic representation that is not in sinusoidal shape that we would like it to be. It seems to be a bit disconfigured. So should we use this data? Should we delete it? Should we report some of this data into the final clinical report? Is there something, or are there some confounders that are major players when taking the data in real clinical world? Of course they are. There are some lists. I'm trying to represent 3 lists today. The first list of confounders is the one that is common to every elastography technique in the world. So transient point shear wave or 2D shear wave elastography. We all know that we have to take a look at some lab liver data, bilirubin and liver enzyme levels. Then there is something about the patients. We have to be sure that the patient has been fasting for enough time period, that the liver is not congested, that the patency of the main portal vein is proven, and that there is no rapid congestion of hepatic veins, meaning that the patient have a right heart failure disease. But if we move on, because we can tell that for point shear wave elastography, alcohol excess or use of diuretic is not that important, are there some confounders that are point shear wave specific? We are very familiar with the nature of the measurement, which has a very low scan failure rate. This is exceptionally low if compared with other 2 applications. The unreliability of the measurement is similar to other 2 techniques. So about 1/4 or 1/3 of the patients are those that are not able to obtain any of the reliable measurements. But what we have to keep in mind is that always when producing point shear wave elastography, we have to have a bit of radiology knowledge behind to show a proper US picture of the liver tissue, to know where to place the measurement in the liver tissue. Also, there is some reported data that the technique itself can have a learning curve, meaning that the first 100 examinations should be done under the supervision of some skilled personnel. Then there is an important one. We don't talk maybe enough of this one. There is a proper lack of quality criteria regarding the technical parameters of the point shear wave technique, meaning many different commercial systems, many different shear wave frequency, sampling rates. We know that there is a big advantage that we can delete some of the measurements in point shear wave technique, but once again, this can be of disadvantage because we are more prone to make a statistical error, even unconsciously, because we are consciously deciding where to measure the measurement. And then there is something that there are some studies done on phantoms that maybe there can be significant differences in liver stiffness measurements among different commercially available systems. Luckily, this same study on phantoms has shown that there is probably very good agreement between the liver stiffness measurements between the systems, and that there is a good dependency operators agreement between the different systems. But when using different commercially available systems, we should always be on alert that they are not the same. Also, we are probably all using the final result in kilopascals. The final result, 5 kilopascals, and then we are all happy because the patient is healthy. Meaning that we have made some computer transformation because the main result produced in point shear wave technique is of course in meters per second. So the calculation that transforms meter per seconds to kilopascals uses many equations that are not always proper to use in fibrotic liver diseases. So there can be a tendency to overestimate the situation with point shear wave technique if we use the final result in kilopascals. Moving to the third table of confounders, we already talked about the liver capsule. Of course, liver capsule is something that is stored beneath the skin of the patient, and the more deeper the capsule, the more difficult to obtain a reliable result. there is some thumbnail data that the results that are measured below the deepness of 5% are usually in effect unreliable. So some solution may be to use a two-step strategy to combine punch away followed by another technique in our computer US system. This would be 2D technique. Another issue, effect of the fat in the liver. Many adverse reports, many eminent authors, many theories. Probably for punch away, good news is it's the leastly affected technique when dealing with liver steatosis. Finally, I know that in 2015, when we were beginning to use elastography in our center, we used to evaluate every result according to the chronic liver disease etiology. Luckily, this has changed, of course, in the direction that we are probably do not need to worry about the impact of the etiology of liver disease, but mainly if we are using the result in etiologies that are well studied, validated. These are viral hepatitis, this is metabolically induced liver cirrhosis and alcoholically induced liver cirrhosis. But having in mind that there is also scarce data in other etiologies, especially in immune liver diseases and congenital liver diseases. Maybe in these instances, etiology could be a factor when dealing with the final result. Okay, these are the tables of confounders, so let's move on to the clinical use of punch away elastography. There are some widely used areas, and then there are some interesting areas for me. Of course, we know that in last years, many applications has come on the market to assess the fatty liver disease or the degree of liver steatosis. We also know that there is some risk stratification involved when dealing or analyzing the result of elastography for our patient. And if VISC elastography will do its magic in the next year, maybe we will even be able to solve the question of liver inflammation. But today, let's stick to the basis. We will just cover the first two topics. The first one is, of course, the non-invasive assessment of liver fibrosis, and the second one is the non-invasive assessment of clinically significant portal hypertension. When evaluating liver fibrosis, as I already said, we express the result in kilopascals, equating this result with some histologic reference. The main reference that is used is the one that was usually used in Hep C patients. This is the METAVIR score. It's consisted of 5 stages. The 0 and 1 are meaning there is no significant liver fibrosis, then 2, there is some or clinically significant level of liver fibrosis. And of course, there are clinically important levels 3 and 4, meaning they constitute pre-cirrhotic and cirrhotic stage. The clinical consequences of this are stated at the bottom of this slide. So whenever we are using the term of F3 or F4 stage of liver fibrosis, there is a clinical term encompassing this disease expressed as advanced compensated chronic liver disease, shortly CACLD. These patients, the ones that are confirmed as CACLD, are always included in the preventive program of screening for hepatocellular carcinoma because they're of enhanced risk of getting this disease. So the clinical follow-up of this patient is very different from the ones that have this stage excluded. We have something now proposed that is coined as a dual cutoff system, meaning that the selection of the patient is done on 2 different levels. The cutoff value of 7, or in Hep B patients 6.5, can be used to exclude or rule out the presence of significant liver fibrosis. And the cutoff level of 12 or 12.1 can be used to rule the presence of CACLD in. I mentioned before the strength of negative predicted value is much more greater than that of positive predicted value. So whenever we have one result of less than 6.5 or less than 7 kilopascals, we can be up to 100% sure that there is no liver fibrosis. Differently, when dealing with measurements that are about 12 kilopascals and that are not about 20 kilopascals, we have to confirm this in a paired system. So one measurement once, and then in a time frame window after 3 or 6 months, and then we can confirm this statistically with statistically great reliability that we can rule CSCLD in. To underline, this is not on the slide, the linearity between the elasticity value and degree of fibrosis is linear until 30 kilopascals, and then this linear interactivity diminishes. So whenever we are applying data of more than 30 kilopascals into the real clinical world, we should do this really carefully. What to do in the dual cutoff world with patients that fall into the gray zone? This is about 20% of our patients, because more than 80% of patients can be correctly classified when using this dual cutoff system. There is some formula proposed by Tsokatis and co-workers, which is reminding us that there is important tendency regarding patients that are over 50 years old, that are male, that have some liver enzyme issues, and that have type 2 diabetes presence. Another thing to do would be to increase the punctuality of one shaver technique, to add another measurement again in 3 to 6 month time frame, to be certain before we proceed to some more invasive method to differentiate the stage of fibrosis or the etiology of disease, probably using liver biopsy. Moving on to the next major area. The most feared of clinical consequences of CSCLD is, of course, portal hypertension, because not only it produces most of the complications of the disease, but also because it's the major cause of mortality in the clinical area of liver cirrhosis. So we are all already aware that portal hypertension produces some effects like fluid retention or life-threatening bleeding episodes, or effects of inflow of toxic substances into brain area, or some major relevant bacterial infection. But how can we monitor the presence or the regression or progression of the disease? We can do this with invasive methods that are well established, well known. This is HVPG measurement via transjugular route, or we can perform upper endoscopy to evaluate the presence of large varices, or this is the short-term VMT. So these are large varices needing treatment. Luckily, of course, there is a chance to evaluate our patients non-invasively using elastography. Of course, we cannot measure the portal pressure, but we can project some statistical data and project or exclude or rule out the presence or the occurrence of varices needing treatment. When doing so, we have a tendency to follow the Baveno consensus. Just a short notice, the next Baveno is taking place this year, so a bit of data that I'm presenting today may change a bit. Once again, we can predict varices only in patients that have portal hypertension due to CSCLD, so with liver cirrhosis of fibrotic type, and with a patient that had no other history of liver decompensation. And also the linearity alert. So the data of the elasticity is in linear conjunction with the presence of portal hypertension until we surpass the 15 kilopascals mark. After that, the linearity diminishes. When following the Baveno consensus, we have Baveno 6 until now, and then there's extended Baveno. We are always suspecting the clinically significant portal hypertension when dealing with values above 20 or 25 kilopascals. But to strengthen our possibilities, Baveno has provided a simple formula to combine the elasticity value and the platelet count value in the blood of our patients. So when combining the elasticity value under 20 and the platelet level over 150, we are to surely skip the upper endoscopy, because the chance of this patient having varices that would need treatment is less than 5%. Of course, 5% is still 5%, but still. There is an even expanded Baveno consensus. This is the second one on the right part, meaning that we can deal the patient who are under 25 kilopascals and who have platelet count under over 110. Then we can omit a bit more of endoscopies. And going even further, there is some add-on of data. Another useful cutoff is the spleen stiffness measurement. Also can be done via point technique. There is a proposed cutoff value of 45 or 46 kilopascals. So when combining these three techniques or these three rules, we can safely rule out about half of the varices that would need treatment, sparing our patient about half of the invasive endoscopies. Following our patients once yearly with Elasto data and platelet count. Of course, some issues, some confounders that need our attention. Can we use Baveno in puncture area? Because knowing that Baveno is mainly consisted of transient elastography using M and XL probe. The answer would be probably yes, but always keeping in mind that there is a possibility of making a clinical judgment error when translating study data from transient to puncture world. There are two groups of patients that need our special attention because Baveno works less perfectly in this kind of patients. The first one is the group of lean patients with metabolically induced liver cirrhosis. They're prone to have varices needing treatment in almost 10% of cases, even with negative Baveno criteria. So better think twice of not performing endoscopy in this kind of patients. On the other part of the spectrum, there are patients who have large photosystemic shunts. These are the patients that indeed do well with Baveno, but when performing endoscopy, then we can see that there are no varices in the abdominal cavity. What is unlucky for these patients is that although there are no varices in the upper gastrointestinal system, they tend to have a high degree of portal pressure, and they tend to have a high risk for the presence of portal hypertension-related complications. Also, when speaking about ruling something out in the field of portal hypertension using puncture elastography, is there some data in the future that we could rule varices needing treatment or clinically significant portal hypertension in? There are some promising aspects with using transient elastography, but regarding puncture technique, sadly, most of the studies, most of the data that is inflowing into our minds is showing that this technique in this form that we are using today will not be useful to rule this entity in. Lastly, speaking about both liver fibrosis and portal hypertension, what to do with the patients that are difficult to assess? So the patients that where the measurement cannot be done or the measurement is really unreliable. We have already mentioned the possibility of repeated measurements. So perform the measurement once, then after 1 month, 3 months, 6 months, up to 4 times with maybe some other operator to see if there is a possibility to obtain a measurement in the patient. Then there is another method to perform a sequential measurement. So combining 2 or 3 different methods using puncture wave, then adding on transient or 2D technique in the same patient. It might be time consuming, but it can help us to evaluate the patient non-invasively instead of using liver biopsy in this group of patients. And of course, lastly, there is always possibility to combine Elasto with some biomarkers, some bioscores. We all know that there are some blood scores like ELF or FIB4 in the liver fibrosis area, or the PLER or anticipate scores in the portal hypertension area. Of course, many more others, but these are just the basic ones. I think we covered the theory enough, so let's see 2 clinical cases, then we can conclude with some video presentations of the method. The first case from our center. This is one of my patients, a male, 70 years old. Nothing much wrong with the liver enzyme system, and when evaluating this system, this patient, we concluded that etiology was a B model, so alcoholic use and metabolically induced chronic liver disease. Performing both Elasto and to better stratify the risk and etiology of the disease, performing liver biopsy. Of course, he was included in the CLCLD group and performed regular HCC screening since 2017. Then there is a catch of Elasto because, of course, every 6 months performing ultrasound, performing Elasto every 6 months. From the first 14 kilopascals, the patient was able to put abstinence, strict abstinence into his life. Also, the diabetes part was better treated with new medications on the market. So there was a stable regression of results to 8 kilopascals for more than 2 years. There was a question what to do with the HCC screening with these patients. Is there a stable regression of liver fibrosis? Does his tendency to have an increased risk for HCC diminishes over the years? And just as we were asking us this question, there was 2021, and there we can see a small 26 millimeter of size nodule in his liver using our ultrasound system. Of course, we performed a CT scan, and as we can see well here, there is some hyperechogenic nodule in the arterial phase of the data, and on the right side of the screen, hypoechogenic in the late phase, showing the radiology the signs of HCC carcinoma. Because the patient was on regular HCC screening, the disease was, of course, proven in the early stage, meaning he was treated with local ablative technique, which is a curative option for HCC treatment. So the relevant question is, in this kind of questions that are evolved dynamically using Elasto technique, would be when to stop performing HCC screening if we are able to obtain stable regression of the liver fibrosis. After 2 years, 3 years, 4 years, 5 years, there is no firm clinical data. So maybe Hep C patients, the patients that are cured of the disease throughout the world, will show us some better understanding of this side of the clinical spectrum. Then moving to the second case, once again, one of my patients, male, 65 years old, once again, just isolated enzyme in the liver lab data, just metabolically induced chronic liver disease. Of course, during the follow-up, Elasto was made, and he was also included as a confirmed CACLD. When performing both Elasto and platelet level, we can see that he's able to fulfill both Baveno 6 and extended Baveno criteria to be a candidate for upper endoscopy. We could not perform the puncture of his spleen because spleen was small in size and it was located too much under the ribcage, so this was not possible at this patient. But according to Baveno, there is a high probability of VNT presence in these patients. When performing gastroscopy, no varices were found. we would be tempted to conclude there's nothing going on in the portal hypertension area in this patient if we were not to perform the whole US exam. These are the pictures showing large portal systemic shunts between the lower part of the spleen and the left kidneys. And the whole picture was a bit better characterized using CT scan. So this patient is now waiting for HVPG measurement to better stratify the clinical risk scenario of his disease. These are some points that I find useful to share with you. Then the last part, this would be live scan and the presentation to show you how to perform point Chevrolet elastography. Of course, we use Esaote and MyLab 9. Firstly, let me show you the patient side of the story. Just a second. So the measurement is taken while the patient is lying on its back, if possible, for at least 5 minutes. Pardon? And it's taken in the side of the right intercostal spaces. To improve the visibility of these narrow intercostal spaces, the patient is asked to rotate his torso a bit to the left and to put the right arm under his head. So this would be the part how to prepare a patient before doing anything with the ultrasound machine. Moving on, the machine part. This is of course our MyLab 9, which has a nice big screen. Then there is this touch screen with the function buttons, and then this is control panel to use the data, to navigate the picture. For elastography of the liver, of course, we will use the abdominal convex probe, and the measurement is started with selecting. There is some Q-Elasto button here on the touch screen, and then when touching this Q-Elasto button, moment, I have problems with my screen. A point Chevrolet application appears on the screen. So now I will press the Q-Elasto button, and then there is our Q-Elasto application. This is the region of interest, the square, where to measure the signal. There is the just a second. There is also this part that shows us how deep we are going into the liver tissue, because remember not to go over the 5 centimeter line. And here on the left, there is a table waiting for 10 measurements to be taken, showing us the median liver stiffness value, interquartile range, so the statistical scattering, and the ratio between the median and IQ error. Next step would be the proper picture and probe position. Let's start with the proper position of the US probe. When performing punch-over elastography, we could see that the proper position of the probe should always be perpendicular to the patient's ribcage, but applying this position without taking too much force on the probe for several minutes could be quite demanding. So what I'm trying to show here, this is one of my techniques for the lean patients. I'm using the first 2 fingers just to grab gently the probe, and the other 3 ones and the base of my palm to stabilize the position of the probe for several minutes. Of course, this is just one of my technique, but there are many others that could be useful so that we can maintain the perpendicular angle for several minutes. Then, while applying the gentle pressure on the probe, we are navigating through the liver parenchyma, trying to obtain a proper image of the liver tissue. when trying to obtain a proper image, just a second, we should always keep in mind that we should show at least a couple of centimeters of, just a second. There are some technical issues with the program. I will wait a second. Okay. So when trying to present a proper picture to make a measurement, we should always make sure that we have at least a couple of centimeters visible of the liver capsule. This is this fine whitish line, and then underneath it, some liver tissue without major blood vessels, bile duct system, or without any other liver tissue, liver vessels that would allow us to take an improper measurement. So this, at the conclusion of the video, there was the capture of the first data. So the patient is holding its breath in neutral position. Then we just press the acquire, and then there's some graphic illustration of passing of the signal, and the number appears on the left of the screen. Moving on, Esaote has some other, I call them nifty add-ons that can help us when improving the visibility and the experience of the measurement. Firstly, if you have, I can say, bad eyes, there is a full screen option, so the measurement can be taken in a larger picture set. Then, if we do not have much radiology knowledge, there is some easy mode selection showed here and pressed here that can navigate us to improve the contrast, the resolution, and the sharpness of the picture using just these three buttons. So using these three buttons, we can improve the image without using the compression, dynamic compression, the XR or XU system. This is for beginners, is very useful and practically really easily done. Another one, moving onward. What we can see here is that when finalizing the report, Esaote will provide us with the proper table of the whole table of results. Then there is some data on the left about the depth of the measurements. There are the final values that I mentioned before, and there is some visual graph of scattering of the data for those that are familiar with the statistic, the position of the final result. So this is the final result or the final report on Esaote system. And lastly, when using Esaote, we can browse through the pictures using our touch screen, pressing this button on the right, and then browsing through the pictures very easily, like on our iPad or like on our iPhone, and analyzing the data that we took before. Let's take maybe just a moment to see how much time it would take me to perform the whole procedure. So to perform 5 elasto measurements in 2 different intercostal spaces on our nurse Claudia, which was really great, which we are really grateful that she helped us with the video. So I'm using the breathe in, breathe out technique. At the deep experience, I'm taking the measurement, and then I will perform the 4 other measurements at the same intercostal space, always watching to make a linearity angle, to keep a perpendicular angle of the probe and of the region of interest square. So this is the fourth one. And this would be the fifth one. And then the other part of the moving to another intercostal space. And repeating the whole breathe in, breathe out technique and taking the data repeatedly until we reach the mark of 10 measurements. Intentionally, I skipped some of the measurements that are not proper, so we can see now when moving to the big screen. That after finishing all the 10 measurements, it took us around a minute or two. We can go to the main screen. That we can go to the main screen. Sorry, once again, something is troubling the system. No, we will have to wait once again. I think there was too much of data recorded, so let's move to the last animation. So that when going to the final shot, of course, all the data seems to be of high quality, but when lately we would analyze the data and analyzing the inert quality system provided by the graphic illustration, you could clearly see that some of this data may be less reliable. Of course, in a healthy patient like this would be less important, but in a patient with results over 10 or over 20 or even over 30, we should carefully analyze both the inert quality of the system, some medium data here, and the graphic representation of the system that should always have a nice sinusoidal shape of the speed of the signal. Of course, some really short messages for the end. I hope I was able to prove that in 2 minutes, so in a very quick time, with punctual elastography, we can assess non-invasively, point of care, and dynamically all patients or most of the patients with chronic liver diseases. It can be used in many areas of patients with chronic liver disease. We talked about the assessment of liver fibrosis and portal hypertension today, but there are many others, some of them I mentioned. I hope I made it clear that although there are many devices, there are many systems on the market, do they provide the same result? Probably not. So when using the data, when analyzing the data, we should always keep in mind that study validated data and systems should be used mostly. And then there is some common talk or common joke that we used to say about Elasto, that even a child can do transient, an adolescent can do point-shell wave, a clinician with 1 day of experience can do 2D application. But when using it in clinical practice, when making tough but important decisions regarding our patient, I think elastography should be reserved for a clinician that has embraced hundreds of thousands of study articles and who dynamically and carefully monitors this rapidly evolving clinical area. This would be all for today, so thank you very much. Thank Esaote once again for hosting the event.
Okay, thank you, Dr. Ari, thank you very much. Let me switch on my camera again. So thank you, because I think that everybody can appreciate for sure that you get in touch with very difficult clinical situation. So, but at the same time, even if the software seems to be easy to use, and I say to you, thank you again to show to everybody how we have to use this Esaote software for the shearwave elasto. Despite the easy way to use the software and to show our unique features, it's very important to remind everybody that behind there is a long study and a long experience, for sure. Not only for the clinical cases that you presented to the audience, but in order to collect, I think we have to collect a lot of cases before to become an expert. This was my question for you, Dr. Ari. I think it's everybody probably in the next future should have the opportunity to have a software like this in his own ultrasound system, because require for sure great experience, because the clinical cases are different. So this is a part of some question that I received. So I try to collect several questions, just one question for you. So what do you suggest, to use more and more this software, to ask to have this software in your own ultrasound system for the future, on liver application?
Yeah, I think the elastography field should be available to everybody in the next few years through major cities and small villages. But once again, as I proposed, the collected data is related to the clinical field only if there is someone with a lot of knowledge behind it. So, of course, everybody can take a measurement and everybody can try to analyze it, but when analyzing and applying it correctly, there should be a couple of subspecialist physicians that are able to perform the difficult cases or to analyze the difficult cases. So maybe there should be some kind of system for mass screening for the patients with normal results, but the results that are above the 5 or 10 kilopascals should always be referred to a person that can provide further clinical interpretation.
For sure, the clinical as well at first. So I think we are in time. No other special question, because I think everything has been clear, both in terms of clinical analysis and the software. What should I say? Thank you to everybody. We are in time. So Dr. Andrei Hari, thank you very much. See you for the next webinar, for the next activity. And let me remind to all the audience that in the next weeks you will receive the invitation for other webinar and other Esaote activities on the web. So thank you again, Dr. Andrei Hari. See you for the next time.
Thank you.
Bye to everybody. Thank you very much for joining.